Good evening to everyone. We welcome you all to this webinar organized from the Inter-American Center for Social Security Studies uh, of the Inter-American Conference of Social Security Studies, and that we realized in collaboration with the American Commission on Organization and Administrative Systems, one technical system of research support. The objective of this activity is to reflect on the progress and challenges of our region to achieve equity in access to primary healthcare services, and where we consider that management strategies are essential to address the challenge we have in Latin America and the Caribbean in terms of coverage, care, and quality that we can offer through health systems. I thank and greet our guests. First of all, Dr. Ricardo Perez Cuevas from the Social Protection and Health Division of the Inter-American Development Bank. Thank you very much for being today with us. And it's a great ally with very important backgrounds because in 2018 he have been part of this great team to deal with all the dimensions regarding social security systems. I also greet with Dr. Svetlana Dubova, head of the Epidemiological Research and Health Services Unit of the National Medical Center Siglo XXI of the Mexican Institute of Social Security. Another of the most important institutions, not nationally, but at the regional level, which is one of the biggest institutions of Social Security, because they even provide health and worker services for the workers and their families. Of the individual needs of the workers. I also thank the presence of Dr. Andre Castillo Banquero that is with us and will share the Costa Rican experience regarding the primary care management strategies in health services, which was very successful. The OCDE was stating that the Costa Rican Social Security services is widely recognized. And we will also have, as a Latin American region, the example of this case. I also greet Dr. Diana Betancourt Loaiza, professor of the Public Health Department of the University of Caldas, which she will be sharing the experience of the priority that has gathered the issue of health since 1948 of the WHO was stating health as a fundamental right, and was where it determined that health is a fundamental right of individual, and that to achieve it, the collaboration and coordination of different technical and social sectors is needed. In this sense, the 2012 resolution must guarantee universal coverage, specifically by means of mechanisms in primary care attention, so everyone would have, especially the poorest sectors of the population, would have access to health. While with the 2015 resolution, the universal coverage was managed, including the financial risks and access to healthcare services of quality, as well as medicines, the access of medicines and of quality. And in 2019, of the resolution on the sanitary universal coverage, the countries recognize that health is, besides a requisite, a result and a transcendental indicator of sustainable development and of the implementation of the 2030 agenda. In this sense, the health social institutes of the region, we have a responsibility, a central responsibility to reach these objectives, and one must and a very important duty to reduce the barriers that limitate the access of people to, an effective healthcare and a quality of the services. Evidently, coverage problems, inequity in the access of health services and of quality is a challenge that is presented in our countries, independently of its income, level of income. The objective that I believe we should have is to take measures to achieve that the majority of the people and communities will have equitable access to health services that they need throughout their lifetimes, in a quality way. The objective of sustainable development, number 3 of the 2030 agenda, establishes that our systems of health, public health should have as the access of health services in order to guarantee a healthy life and to promote the well-being for everyone at all stages of life. In terms of coverage, we should center the efforts and the attention in counteract all the economical barriers that prevent the access to medical access. In order to achieve this, health services must need a lot of things, especially to have healthcare staff competent, as well as an amount of knowledge that provides medical attention focus on the people, as well as necessary needs that will invest in universal coverage. At the same time, we will also need a definition and implementation of public policies and actions with a multi-sectoral focus that will tackle the determinants of the health determinants to promote health in the population. We are in complex times that are changing by a lot of factors, especially by epidemiological and demographical patterns that the region is experimented. So these inequalities of health in the region must presents a challenge. By this reason, it's really important to exchange ideas regarding the strategies, regarding the primary care management strategies, and to check all the experiences of our member countries, because if each of us have managed to do a lot of different kind of strategies, and we can together can manage to make a reflection on this. Each country have found regarding its economical, political, and social circumstances their own way, but we have to find a point where we can find ourselves as countries to implement a better healthcare services. I I hope this will. I thank to all of the panelists and all the attendees, and thank you for your participation. I give the floor to the coordinator of this event, Maestro Carlos Ivan Garcia, to start the speeches of the panelists. Thank you very much and have a good day. Thank you very much, Dr. Emilio Carrasco Gonzalez, Executive Director of the Inter-American Center of Social Security Studies, for the presentation and for your welcome words to this webinar. We have to highlight that this activity is circumscribed to one of the 4 strategic axes in the work plan of the American Commission of Administrative Systems for the period 2020-2022. The interest of the American Commission to tackle the different experience of management and human capital in health and social services that are delivered in the different social security systems. So I will give the floor to our guests who will help us to tackle these matters. And taking into consideration that Dr. Emilio Carrasco have made the context, I would start with a little CV summary of our first panelist. Dr. Ricardo Perez Cuevas is surgeon with a specialty in family medicine. He has a master's degree in medical sciences by the National Autonomous University of Mexico. He has a master's degree in international health at the Johns Hopkins University, as well as a PhD in public health at the National Institute of Public Health in Mexico, and a postdoctoral studies at London Imperial College. He has served as a coordinator of health policies at the Mexican Institute of Social Security, and he's a coordinator of advisors of the Undersecretary of Prevention and Promotion of the Mexican Ministry of Health. In addition, he has collaborated in research studies in health systems, public health, and health policy with researchers from the Universities of Harvard, Berkeley, Miami, Montreal, the West Indies, and the WHO. He's a member of the National Academy of Medicine in Mexico. He was also director of the Center for Health System Research at the National Institute of Public Health in Mexico. He's currently a senior health specialist at the Inter-American Development Bank, where he has led projects aimed at financing health policies, medical and digital infrastructure, as well as health programs at the Bahamas, Jamaica, Mexico, and Nicaragua. Well, welcome you, Dr. Ricardo Perez Cuevas. I give you the floor. Thank you very much. I'm going to share my screen. Well, the topic of primary healthcare has been always very interesting and a challenge to tackle. It's like the holy grail of the health services. Which are the advancements? Let me tell you a little bit. What is the situations of health systems in Latin America? I will tackle three things. The first thing is that in Latin America and the Caribbean countries, all the countries consider health as a fundamental human right. These countries use different forms of organizations for their health systems, governance, and service provision. And we also face a major challenge in the provision of quality services and in achieving health equity. This is a very important topic. Which are the problems that are tackling? Let me tell you four in particular. The first one is the fragmentation in organization and service delivery. We have several organizational arrangements, different structures. I work at the Caribbean nowadays. There are countries that they have 400,000 inhabitants, such as the Bahamas. They have a fragmented health system. The second problem is the financing schemes, which are different. They have different models. These financing schemes can only have four sources. The first one, fiscal area, that is what the governments give. The second one is the taxes that the workers give to the social security systems. For example, in Mexico, is linked to medical services. And the third one is the spending, the individual spending, which is very important. And the fourth one is the donors. So several countries, such as Haiti, a great amount of its financing comes from donations. Despite we have little money, we have a lot. We have several problems to monitor and to organize, and this systems. We cannot manage to organize them all. At the population covered by the different schemes differs between and within countries, and this generates inequities in health. They're like these are like I believe the most important problems. We have here an example of financing and coverage. As you can see, the main source of basic health care coverage, we have two divisions. The coverage based on the place of residence, which is fundamentally task one. You can see here the countries: Argentina, Belize, Brazil, etc., Jamaica, which I am right now, Paraguay, and Trinidad and Tobago. But the contributed healthcare coverage has different arrangement. For example, a single payer, such as Costa Rica and Uruguay, and also a multiple insurer with automatic enrollments, such as Bolivia, Dominican Republic, Mexico, Panama, and Peru. And then we have a multiple insurance with a choice of insurance options, such as formal employments in Argentina, Chile, Colombia, Guatemala, and Suriname. As you can see, the arrangement in health coverage are very complicated. And this we have to add, for example, Mexican case that I know it better. The user service of users are migrating from one system to another. For example, when they change employments, when they have, and the user can apply for an insurance. If we focus to primary healthcare services, I would insist that, from my standpoint of view, it's the holy grail of the healthcare services. Because why? Because they are the first point of contact for people with health services. It's unexpected that unfortunately we cannot manage to achieve. It's centered in the people. The majority of the services are still designed around the services, but the people has to go to look for the services. Accessibility, comprehensive and close to the community is a very important attribute. They have to be coordinated with other levels of care. Good primary healthcare services solve up to 85% of the medical attention without taking into consideration public healthcare. The problem is that we have to allow quality service. For example, in the patients that live with a chronic disease, and they must guarantee that all the services will be with the maximum quality possible. The third one, if this can be achieved, it is possible that it's a positive impact in the health of the population. A director was telling the importance of the health in the population is related with a lot of things. For example, the children, that they can grow healthy, that they can learn in adult population, that they can be productive, and in the case of elderly population, that live a very a good life. So we have really big issues in the impact of the health. We are talking of the cost of the services, and to maximize these services, they have to be efficient. Why? Because they avoid hospitalization. For example, they reduce healthcare costs. For example, a patient that has diabetes, especially when they are not well attended, the probability that they go to the urgent services is incremented. When they are good in a good care, this reduce the health costs. In the primary healthcare services, regarding hospitalization, we have made analysis at the bank that which is the proportion of the hospitalization that we can avoid, and in consequence, this reduce the healthcare cost. I want to highlight the reduction of healthcare cost. please visualize a long line, that an endless line. When we manage to be more effective, we are going to attend more people, but this is not going to end. The cost will keep rising. Here, there is an example of basic primary health coverage in the Latin American and the Caribbean countries. So I would like to highlight that the majority of the countries have a basic coverage, an automatic coverage, basic coverage. That means that this is the proportion of its population that it covers. For example, in Argentina and Belize, it's the 100%. There are other countries that they combine the automatic coverage with a compulsory insurance coverage. For example, the case of Colombian medical insurance. The same happens with a voluntary coverage. It's worthy to highlight in Mexican case. Unfortunately, we have a compulsory insurance coverage that covers almost 46%, more or less, and a voluntary coverage that is 37%, but we have a 17% that are not insured. In the case of Panama, we have 30% of the population without any insurance. Good news from my point of view is that this basic primary coverage is available for almost all the population in Latin America. This is somehow, at least for me, it's very good news. Which are the three challenges that are very important to highlight? The first one is the burden of disease with a predominance of all the chronic diseases. The second topic is that the health services must improve in terms of sufficiency, efficiency, and quality. And the third one is precarious financial and fiscal sustainability of healthcare spending. Pandemic was a the pandemic shows the precarity of these systems. Regarding the topic of the universal health care coverage, is the commitment to ensure that all the people must have access to good quality healthcare services when and where they need them and without any financial hardship. How big is the prevalence of chronic diseases in Latin America and the Caribbean countries? It's a complicated graphic, but I would also like to highlight what is the proportion of obesity. You can see in a descendant order the obesity proportion. With obesity, the orange bar is the cases with hypertension, and the gray one is those cases with diabetes. As you can see, we have a great problem in because more than the population in Latin America is overweight or has obesity. Approximately the 20% we have hypertension, and between the 5 and 12% we have diabetes. What does this mean? A very important burden of the disease, and also the chronic disease patients are frequent users. The second thing that I am showing is that this trend in chronic disease prevalence is upward. It's not going to decrease. As you can see, it's simply between the year 2000 and 2040, the same chronic diseases, cardiovascular diseases, cancer, um, cirrhosis, and mental disorders are the main diseases, chronic diseases. If we think that it's not going to reduce, we have to be clear that the healthcare services must be prepared to deal with all these very complex diseases, which we are not at this day. But it's important to highlight that all the programs must can de-accelerate the incidence and the mortality by chronic diseases, but they are not going to stop this upward prevalence. The second point is that we don't have enough health staff within the region. Health staff is like the vertebral column in the health systems. This shows how has been modified between the year 2000 and year 2017. As you can see, then it should be according to WHO. You have to be 44 personal staff by 10,000 inhabitants, combined doctors and nurses. If we took only the physicians and the 40 would be the issue, the majority of the countries cannot manage to have the resources. The only two countries that manage to have this is Cuba and Uruguay. This reflects two things. The first one, importing physician from one country to another means only that we take these physicians to another country. The issue here is that these countries should have the enough physicians to export these physicians. But anyway, it's not enough to. It's not enough for the physician deficit that we have. The next thing is in what kind of services are offered. The only thing that I would like to highlight is the majority of Latin American and the Caribbean countries, health professionals provide primary healthcare services. Only in Colombia and Uruguay, for example, these services are provided by public and private primary healthcare clinics, while, for example, in Guatemala, these services are provided by nurses in health centers. The arrangement are through physicians and nurses with university formation. And in Guatemala, for example, these services are provided only by nurses. So the task delegation, which is a very important topic, is very attractive in primary healthcare attention. But we go to the basic issue. If we don't have enough staff, and besides we are facing a chronic disease epidemic, and those who are dedicated for the chronic diseases thought that the best model is a multidisciplinary model, then we have a serious problem on how can we are going to solve this problem. This is the second part of the slide where you can see that the majority of the services are provided by professional. The problem also is that the money is not enough. This transparency shows us that healthcare spending is increasing in Latin America and the Caribbean. In all the countries, it has been increasing progressively since the year 2000 and the year 2018. In Brazil and Chile has increased this substantially. If we can see it in perspective, it is possible to see that the healthcare spending is increasing, but we can see the next problem. What I would like to highlight that the financing systems that varied widely in Latin America and the Caribbean. What can this be? Why this is important? See, for example, Cuba has 89% of spending, fiscal support, and only 11% of the personal spend. And the other way, you have Haiti, 44%, and only 10% of task financing. All the arrangements are quite different. And this impact in the availability of resources, naming physically or human, in order to achieve the goals. There is the universal health coverage. You can see in this universal healthcare coverage, they are dividing this in by populations. Children, for example, adults and elder people. And they classify it by promotion, prevention, treatment, DTP3 coverage, which is the universal vaccination coverage, and then the handling that is related with transmissible diseases and healthcare reproductive systems, and a great deal of proportion is done by chronic diseases, leukemia, diabetes, stroke treatment, including cancer. This is the metric of the 23 effective coverage indicators, which are included in the Universal Health Care Effective Coverage Index, published at the Lancet magazine. So the access to effective universal healthcare coverage still has a long way to go in Latin America and the Caribbean. Colombia, Costa Rica, and Canada, Chile, Cuba are the countries that are the best effective universal coverage. In exchange, and other countries, for example, only in Mexico, for example, we only reached 61 points of universal health coverage. We are, for example, in Haiti, which has 36 points. So indeed, we have an important problem in relating how much money do we spend, how is the available healthcare staff in order to achieve a universal healthcare, an effective universal healthcare coverage. And well, I will finish my participation here. I thank you all. As you can see, the challenges are still very important. And in this moment, I thank you very much the invitation and the opportunity to present this. Dr. Ricardo Perez Cuevas, thank you very much for this analysis of the status of the healthcare systems and what is happening in our region, highlighting the role of healthcare or primary care management to prevent chronic diseases. This is where all the system lies, in the sense that if we would manage to solve the primary care attention, we will solve more than the 80% of the people who goes to find any health services. If there are not preventive measures to attend certain diseases derivated of not very healthy lifestyles, if we do not educate children to eat healthy, to do exercise, well, eventually these chronic diseases will be presented and specialized medical attention will be demanded. Regarding these three challenges of burden of disease, of these chronic diseases, that is not going to decrease, we must improve the efficiency in primary healthcare attention, as well as the precarious sustainability. I would like to say that at the end of this webinar, we will have a session of question and answer. And now we will continue with the presentation of Dr. Svetlana Dubova. She's a physician with a specialty in pediatrics and family medicine. She has a master's degree in health sciences with a concentration in health systems by the National Institute of Public Health. She has a PhD in sciences at the National Autonomous University of Mexico and a postdoctorate in international health at the Harvard School of Public Health. Doctora Dubova is head of the Epidemiological Research and Health Services unit of the National Medical Center Siglo XXI of the Mexican Social Security Institute, and she's a national researcher of the National Research System. Dr. Dubova has participated in several multinational research projects in health systems. She has also collaborated in the Lancet Global Commission on high quality health systems and has participated in the public opinion survey on perceptions and experiences with health systems in Latin America countries with the Inter-American Development Bank. Currently, Dr. Dubova is collaborating on several projects with researchers at the Harvard School of Public Health, Miami University, California University, and the Sorocaba University in Brazil, as well as the Cayetano Hereda University in Peru, among others. Dr. Dubova is associate editor of the journal BMC Health Services Research, and she's also author and co-author of more than 100 scientific articles. Her main lines of research include health need assessment, quality care, of care assessment, design and evaluation of innovative models of care. Thank you very much, Dr. Svetlana. I give you the floor. Thank you very much. I am going to share my screen. So, to talk of the Mexican experience in the management of the first level of attention, we have to state the characteristic of the health sector in Mexico, which is fragmented and characterized by several health systems that covers several segments of the population regarding of its employment status. They operate through various financing schemes and sources, and each scheme has specific benefits and rules for the access to services, to health services. We have to know also that the first level of attention is, as Dr. Ricardo Perez has already stated, are the primary care services, the entry point to the system, and the link with the community. The main functions of primary care are involve public health through health promotion and primary prevention of diseases, early detection, which is secondary prevention, and tertiary prevention, which is the disease management through an effective disease management. Nevertheless, the primary attention services reflect the fragmentation of the Mexican health sector. Each health institution has a network of primary attention facilities and mobile units. There is no one unified primary health care service model. The Ministry of Health has implemented different primary health care without success and without joint participation of all the health institutions. There are important gaps in the availability of infrastructure and competent primary healthcare personnel. At the same time, the Mexican population faces increasing risk factors for non-communicable diseases. For example, 75% are overweight or obese, which are the highest prevalence among the countries, which the average is the 65%. 61% are sedentary. They do not practice any exercise. Half of the population doesn't eat fruit or vegetable, 30% smoke, and 20% drink alcohol in excess. These are reflected in the in prevalence of diabetes, cancer, and some other non-communicable diseases are increasing. Prior to the COVID-19 pandemic, primary healthcare services performed really poorly. For example, Less than 70% of child immunization and contraception was covered. Less than 16% of adults had been tested for diabetes and hypertension. Less than 30% of the women had been screened for cervical or breast cancer. And less than 45% of the population received healthy lifestyle counseling. The services of public health had a limited involvement in preventing the spread of COVID-19. The health authorities adopted a sample-based sentinel surveillance model to monitor COVID-19 cases. Also, they implemented a epidemiological traffic light system to communicate the severity of the COVID-19 pandemic and implement public containment policies. Nevertheless, they were diffusing a contradictory message for the use of masks, and we have weak measures for quarantine or of cases and contacts in order to prevent controlled transmission. The primary healthcare services participated in the prevention of the spread of COVID-19 very weak then. Through COVID-19 respiratory triage in primary healthcare facilities, and the Ministry of Health implemented the detection and care strategy for remote communities within the framework of primary health care. Nevertheless, COVID-19 vaccination was provided by the government, not by the Ministry of Health. Primary healthcare facilities were not directly involved in these activities. Essential health care promotion and immunization services were reduced. For example, at IMSS, from April to December 2020, compared to the year prior of the pandemic, contraceptive services were reduced to minus 50%, and childhood immunization were reduced to minus 36%. The primary healthcare services participated in COVID-19 secondary prevention through COVID-19 case detection respiratory care models, and also the passive screening for COVID-19. Nevertheless, the primary healthcare services decreased the early detection of non-COVID-19 related diseases. At IMSS, for example, from April to December 2020, in comparison with 2019, breast cancer screening by mammography dropped to minus 79%. Cervical cancer screening dropped to minus 68%, and prenatal care dropped to minus 20%. 27%. Primary healthcare staff participated in identification and management of low-risk COVID cases. For example, at IMSS, primary care teams in respiratory care models were installed, called MARS, where they realize separate care of COVID-19 patients, management of mild cases of COVID-19, health surveillance of home isolated individuals, referral of patients from primary healthcare clinics to hospitals. Also, the accelerated implementation of telehealth services such as medical consultation, triages, monitoring, and follow-up of patients with COVID-19 and information to public. Also, the teleeducation of healthcare professional was implemented. The primary healthcare services failed to maintain essential services during the pandemic. A high proportion of essential primary healthcare visits were canceled or postponed. Renewable prescriptions were implemented to reduce visits for patients with non-communicable diseases. At IMSS, the visits of patients with diabetes and hypertension decreased less than 32%, and the visits of sick children were also decreased to minus 66%. The 2021 IMSS National Satisfaction surveys revealed that 40% of the users were dissatisfied with primary healthcare services. The main reasons were the long waiting times, shortage of medicines, lack of health personnel, and discordance of the staff. Which are the lessons learned from primary healthcare response to the COVID-19 pandemic in Mexico? The to the They included this weakness, short-term governance and funding at the expense of a true vision for investments that could strengthen the long-term resilience of primary health care attention. The primary healthcare attention services were ill prepared to respond to the COVID-19 pandemic. There was a lack of funding, shortages, and reallocation of health personnel to COVID-19 care, as well as the deficiencies in infrastructure, equipment, and supplies reduce the capacity of primary healthcare attention, as well as a lack of robust and reliable epidemiological surveillance systems with extensive screening and quarantine and the quarantine of cases and contacts to control transmission. So it is we need to strengthen primary healthcare attention to perform its functions that will allow it to be resilient, prevent and reform efficiently to the increase in chronic diseases and future natural and environment disasters, including new pandemics. To this end, it is necessary to promote governance with a forward-looking primary healthcare attention vision and that make a decision based on scientific evidence. It is also necessary to increase the share of the health budget allocated to primary healthcare attention. This budget should be protected and be significant enough to strengthen the primary healthcare attention infrastructure and workforce. Finally, it's necessary sufficient work for train and with the required protection, which we couldn't find it during the pandemic. It's also necessary to build a reliable epidemiological surveillance systems. It's also necessary to implement and integrate functional and efficient telehealth network throughout the country with established systems and procedures. It's also necessary to ensure a high degree of transparency of the resources allocated to health and the results obtained. And it's also necessary to promote the participation of the population in public health issues. Thank you very much. This will be my presentation. Thank you very much. We thank Dr. Svetlana Dubova. She put in perspective the status of Mexican health system, of all the characteristics of Mexican population and the challenges that faces the health system in Mexico, the role of the first primary attention healthcare in the framework of COVID-19 pandemic, and how all the implementations were organized to implement measurements to avoid the COVID-19 pandemic to be spread. And to mitigate this tendency of a short-term view, and to the international cooperation is also important, which is an objective of this activity, to generate the spaces and the exchange of ideas, because each country has go by different paths, such as Dr. Carrasco was stating initially, but nevertheless, it is necessary to make these kind of activities to generate this exchange in order to reach the possible points of agreement, so the rest of the countries can learn of this lesson learned in Mexico and the rest of the countries of our region. Uh, uh, We have received a lot of commentaries and questions at the chat box that we will read them at the end of the presentation of Dr. André Castillo Barquero, which I am going to. Uh, he has a degree in medicine and surgery at the Hispano-American University. He has a master's degree in palliative care studies by Santa Paula University. He also has a master's degree in administration of sustainable health services with an emphasis in management by the National State University at distance, and a master's degree in public health with emphasis in epidemiology by Santa Lucia University. He holds a diploma in hospital and public institutions management by the Central American Institute of Business Administration. He's currently pursuing a PhD in public administration and business sciences at the Central American Institute of Public Administration. He has been part of the Integral Health Assistant Program and also has been a university professor at the Hispano-American University and the International University of the Americas. He has worked at the CIMA San Jose Hospital, at the Dr. Solon Nunez Frutos Clinic of the Costa Rican Social Security Fund, and at the Dr. Rafael Angel Calderon Hospital. He was assistant in the general direction, head of outpatient consultation and operating room manager at the Hospital Mexico. He was medical evaluator of hospitals in the Health Services Purchasing Directorate and general director of Hospital Golfito Manuel Mora Valverde. Currently, he is the head of outpatient consultation at Hospital Mexico at the Costa Rican Social Security Fund. Thank you very much, the Dr. Ander Castillo. Thank you very much. Thank you very much.
Doctor.
No, no lo
Doctor,
escuchamos.
no lo escuchamos.
¿Ahora?
Ah,
We
listo.
can-
Ahora sí. ¿En dónde me quedé? No me escucharon del todo, perdón.
Sí, doctor, si podría volver a iniciar.
Listo. Bueno, les decía que gracias por
Well, I
la
was
palabra.
saying thank you, Maestro, and good evening to Dr. Carrasco, Executive Director of CIS, and all the panelists that are with us this evening. Doubtless, I would like to thank all the participants in this moment.
Bueno, creo que, bueno, como ya dijo el maestro, mi nombre
As my name is André Castillo. I work as a Costa Rican Social Security Fund
el Hospital México.
in Mexico, Hospital Mexico from the fund.
La experiencia
I'm going to give you today the Costa Rican experience in the management of the first level of attention.
Bueno, como generalidad de Costa Rica,
As a generality of Costa Rica, in Costa Rica,
República Centroamericana,
is a Central American republic with almost 52,000 square kilometers.
habitantes. Es una república
It's a presidentialist republic with 7 provinces, 84 cantones, and 88 districts. At the left side, I would like to show you that Costa Rica is in the north of Nicaragua, and at the south, they have Panama. We have 2 coasts surrounded by the Pacific, and the east, we have the Caribbean or Atlantic Sea. So I would like you to see this image very well, so you can have a knowledge of the specialty of Costa Rica. In Costa Rica, we have a Costa Rican health sector, which is comprised by several institutions.
La primera es el Ministerio de Salud,
The first one is the Ministry, Health
que es
Minister,
el ente rector de
that
todo
is the
esto.
one who organizes everything.
Tenemos a la Caja Costarricense del
We have the
Seguro
Social Security, Costa Rican Social Security Fund.
Social, AIA, quienes son los encargados de los
Which are
acueductos
the
y alcantarillados, Ministerio de Agricultura y Ganadería. Tenemos al ICODER, que el ICODER es el Instituto
we
Costarricense del
have the
Deporte y la
ICODER, which is the Ministry of Sports. We have also the Ministry of Agriculture. And cattle breeding.
Instituto Costarricense de
And
Investigación
in is the Costa Rican Institution of Nutrition and Health.
los CENSINAI,
We have the CNCNI, which is the education, nutritional, and children centers. And at least we have the Patronato Nacional de Rehabilitación.
Doctor André.
entrar hoy a
We are going to focus on the Costa Rican Social Security Fund, which was created November 1st of 1941.
La Caja cumple una función
The Costa Rican Social Security Fund
institución pública
is a main public institution
de Seguridad Social
which is in charge of all the health systems
de salud y pensiones
because he
fundamentales
because
del desarrollo social y humano.
it is in charge of all the health system and the pensions within the country, and we believe that is essential in the human development. Since this foundation has been compressing programs and policies regarding health issues according to the times and the development of the country, efforts have been made to integrate all the services in order to reach all the regions based on the resources that the country has. It is because that the Costa Rican security system is organized around the Costa Rican Social Security Fund, which is regulated by a compulsory payment of all the workers as well as the pensionists. The payment of those who are poor are going to cover all the workers. So this is the building of the Costa Rican Social Security Fund, and at the right side you find the logo. It's a mother with a children of on a basis, a solid base that protects these children in the logo. The fund divides administratively health services, which are divided in this region through the e-base. These are integrated webs of health services service provided. The Northeast, the East, and the South at 2019, but up to 2022, it is divided in integrated webs of health services, and these are the seven. The country counts with 7 provinces, but the provinces are not the same as these integrated webs. We have the Chorotega, the Central Pacific, and the Brunca. We have at the north the Huerta, the central north and central south, and the Huerta, the Atlantic Huerta. So as you can see here, the organization of health services of the fund, we will have 3 national general hospitals, 6 national specialized hospitals, 8 regional hospitals, 12 peripheral hospitals, 6 specialized units, 105 health areas, 527 e-waste installments, 636 periodical visits, and 1,082 e-waste. As we can see here, we have like the community, the family, and the individual, which is looking for toward attention. We have a first level and then the second level comprised by peripheral hospitals and regional hospitals. And the third level are the national specialized hospitals. This is a more complex level, and always there is going to be a connection between these three levels. Here we are going to the first level of attention in Costa Rica, which is it's comprised by 105 health areas, 1,083 e-bays in all the national territory. The e-bays are the first line of health services to which the professionals go to have a periodical consultation. As well, we have a 636 installations to give a periodical visit. Later, I will explain this. So the first level of attention will have these groups supporting. A base means a basic integrated healthcare team. The basic team is comprised basically by a general physician, by an auxiliary nurse, by a technical assistant for primary healthcare attention, a network assistant, and a pharmacy technician. In some cases, in these centers, you can have a support team that could be a nursing, pharmacy, family and community medicine, nutrition, and psychologist, a dentistry, social worker, and clinical laboratory. But these are support teams. They are not basic services that are provided in the 100% of the basic integrated health care centers. In this image, what we can see is the distribution of the health areas and the e-base. In the different webs, where the central part of the country is almost 50% of all of them. And this highlights the gaps between the central part of the country and the coast parts. In the left part, we have the health areas, and in the other part, we have the e-base. This with the date of the June 30 of this year. If we make an historical analysis from 2005 to 2022, an average of 6 new basic integrated healthcare team were created per semester, and an average of 1 basic integrated healthcare team is inactive, according to this historical series. And in this experience, we have an effective increase of 186 e-base. In this graphic, we can see the number of basic integrated healthcare team at the national level according to the formation and report by semester in the period of 2005 to 2022. The goal is to achieve 4,000 to 5,000 inhabitants But with the images, there is an important gap still in the country. Everything is focused on the center of the country, but we've been growing slowly. In this image, my intention is to see that the totality of the first level of attention that the fund has, much more less than a half are belongs to them. The buildings are property of third parties rented, and this can influence in the quality of attention that is brought to all the insurance. With these images, I would like to show you the healthcare attributes. We have an acceptability, which is an attribute that all the users should have. It's like a perception on the services, and which they have to be secure. They have to be there have to be a continuity on the of services. It must be efficient regarding the production of the available resources. It must be effective. This means that the health problems must be controlled. And the most important thing is it that the majority of the population must have access to these services. Costa Rica made an evaluation of health services provisions in these three levels of attentions. From more than 50 years ago, this evaluation started the medical management called the health services purchasing insurance. At the first level of attention, the intention is that when a patient arrived to and received this attention, this medical attention, would be provided integrally the medical consultation. So the objective of this health service delivery evaluation has these objectives. The first one is to assess the fulfillment of the main institutional objectives in relation to the provision of health services. The second objective is to provide the institution with strategic information for decision making at all management levels. The third objective is to contribute to the permanent process of accountability. And the fourth one is to promote the continuous improvement of services. So these objectives leads to that in each populational group, you can have this attention that will be evaluated each year. If we focus or we see, for example, in children, what we are looking is detection and appropriate management of anemia in children from 6 to less than 24 months. Also, in this group, we seek to a timely detection of dyslipidemia in children from 9 to 11 years of age. In a populational group of children under 1 year of age, teenagers and women in pregnant women, what we are looking is the early detection of metabolic, genetic, and endocrine system diseases in newborns. We have also the coverage and recruitment of children under 1 year of age, postpartum, and pregnant women. We also have the timely detection of diseases that affect maternal and infant mortality. In adults and the elderly, the coverage and control of care of people with arterial hypertension and diabetes type 2. Also, we have the detection of chronic kidney disease. Cancer is another health problem The point is to make an early detection, especially cervical, breast, and lung cancers. So if we make an analysis of the health services situation in Costa Rica, we can say that there is no standardization of the services offered at the level of care. There is an inequity in this attention given to the patient. There is a significant variability of available resources, must be human, infrastructure, equipment, and services. We keep with the traditional working hours and schedule, which means that the attention is not 24 hours 7, and this have a lot of problems, leads to several problems. We have a single institutional health information system that has limitations, and we lived already when we were at the COVID-19 pandemic and the hack of the fund. If we don't have internet, for example, or the information is still, it's a problem. So it's a challenge that we have. There is an excessive increase in referrals to specialized care at levels 2 and 3. We have to make innovation in the provision of services responding to the professionals' own interest and not to the institutional interest in response to the needs of the population. So the first level challenges in Costa Rica has these challenges. For example, to make a quantification, allocation, and definition of gaps per network, including the economic studies, which are determined in our region. Of course, Costa Rica is not a single one. We have to make a better resource planning. We have to provide better infrastructure and equipment at the first level. Less than 40% belongs to the institution. We have to strengthen the institutional technical body responsible for the implementation, monitoring, and follow-up evaluation of the process. We also have to strengthen the staff training and the educational process, as well as the research and teaching. We have to strengthen this all the information of the patients. We have to improve it in order to offer a better services to all the members. But the main challenge is that we cannot forget to encourage that the health services delivery model to be patient-centered for the continuous improvement of the quality of care and its effects on the health of the population at the first level of attention. Thank you very much. Thank you very much, Maestro André Castillo Barquero. Thank you for sharing this experience in Costa Rica regarding the strategy of primary care management strategies. Such as Dr. Carrasco was saying, is one of the successful systems. We have a possibility to copy this eBay experience, but we will wait for at the end of the webinar at the session, question and answer session. So we are going to welcome Dr. Diana Betancourt Loaiza. She's doctor in public health. She has a master in nursing with an emphasis in family health. She has a master also in primary care research and specialist in health promotion and health administration. She's lecturer in the Department of Public Health at the Caldas University and professor at the University of Manizales and the University of Antioquia. She is director of specialization in epidemiology and of the journal towards the promotion of health of Caldas University. She is coordinator of the collective action, social movements, and sociocultural change program. She's author of books, book chapters, and scientific articles in national and international journals related to health promotion, parenting, primary healthcare education, and family health. She is part of research groups such as promotion and disease prevention, healthcare and human life, CUSABI, as well as health and society. I give you the floor and welcome you, Dr. Loaiza. Well, good evening to all. Thank you very much for the invitation, for taking into consideration my participation of the Colombian case. I've been listening all the interesting presentation of today. I would like to know whether you are listening and whether you are seeing my screen.
Correcto, doctora. Estamos viendo su presentación.
Indeed, doctor. So I'm listening my partners, and I believe that it is so important the governance and the health systems, which is very important for the first level of attention works. But evidently, and particularly in our country, in Colombia, we have a lot of errors because we have not centered in a process of morbidity. Edmundo Granda was called public diseases. So we have a very important challenge within the micro context. That's why I would like to share my experience, my territorial experience, public policies, and this is one of Colombian experience of first level of attention management, because we in Colombia have a lot of experiences. I would like to start with this article that I wrote in the past years with Dr. Carlos Calderon. I invite you to share your teamworks. It's called Primary Health Attention, a global view to orient ourselves in the local. We make a process of reflection that emerged at a symposium that we organized in Colombia, and that we are in the fifth session of the symposium, which is called Social Primary Attention. Why social? It's a linguistic fight that we have at the Caldas University, because it has been a model taken by the WHO as a successful experience. This linguistic fight aims that the responsibility should not burden on the health teams only, but the healthcare, the primary attention is a responsibility of all the disciplines and all the sectors. At the global level, we made this article reflecting that primary attention is not the first contact with the community. In Colombia, we've had as well some errors in thinking that this scheme allows us to make a context, and we can see structural elements from the micro till the macro levels. Going through the very complex and different this demands to have a navigation flexible, fundamented, and contextualized that will help to identify the dangers, as well as with tripulations to assume the work and the responsibility to go and check with honesty the errors and the things that we have done. We have organized this in three axes. uh, which is a economic and and social politics, would have to be with funding that would not be only from the resources that are based in the individual and not in the collective. There are some collective elements, but that ends up to be traditional strategies that really does not transcend. We talk of a sanitary policy that is very important, in which the social participation is very important. I'm talking for the context of Caldas. We have a lot of problem with social participation because it's not only the community leaders, but the communities in itself. And we, as integrants of the community, we are part of that community and that society, and we have to participate because we have to stop thinking that the things are going to be solved from the government down. We have all we've listened to all the participants of the community, and it's a very important strategy to reduce the gaps, the poverty gaps, to avoid hospitalizations, to generate a better lifestyle quality. But when we go to concrete these strategies is where we have had the difficulties. So that recognized must be accompanied to be something concrete. The topic of the university, the primary healthcare attention has not been put into focus. So it is very difficult that the professional, when they finish their studies, can can do something when they cannot understand very well what is going on at the first level of attention, because we are not going to center in the diseases topic and in an individualistic perspective. The topic of primary healthcare attention in the micro contexts that are related with this first contact, such as how we arrive to communities, how can we manage to talk with them. More, we have to accompany them and be able to provide them the tools they need to tackle these diseases. The orientation to the individual is related with social determinant, with a context uh, that is situated. And if we does not take into consideration this, we are not going to solve the problems. Continuity and coordination is a teamwork. There are elements that I cannot detail, but can you find in the article? This axe, you can also find it visually is very powerful because we have we take into consideration the people, and we cannot see them in an homogeneous way because of course they have different ages, different genders, they have different cultures, the families, the communities, the social classes, and their biographical paths. Therefore, we cannot homogenize everything because we're going to fail in our attempt. The scientific reference, we always think that this primary attention is undervalued, starting from the students' formation, but they have a very important scientific reference, and we have to have powerful theoretical reference that would let us to understand why the communities are behaving in a specific way. What does they think? And how can we understand those dynamics? That's why it's important to work complexity and critical thought, the values, the ethical coherence, the study and professionality, and the commitment. And we have also to take into consideration these contexts, which are socio-economical, political, and sanitary contexts. This states, in a way, a reorientation of the action of health public on public health. We have to take into consideration the social determination of the process of health, disease, and then and death. We have to see them as a process, as a continuum that can work together and where we can understand the communities and how the communities understand and how they feel within this process. The territory is something that we have been working. Territory and public health. If we do not understand the territory where the people live, well, we are not going to help them because people have some meanings and they have symbolic perception on what a territory means for them and they and how they move in those dynamics. I I talk about to intervene in the territory, and therefore when we go to the territories, it is very difficult from the health sector to reach any solution. It is very complex because when we go to these territories, even with the medicine student or nursing students, almost all the causes of those diseases are socials. So if we don't go to the territories with other disciplines, we are not going to help these communities and these territories. And then we are not going to take into consideration the people as individuals that can be listened. So and so what is going on in their territories. So this process of health, disease, and death cannot be understood in this if we do not take into consideration this historic social dynamics. We have to understand the context. With this brief introduction, I am going to tell you about this book. I know the time is really short, but just the health system is a part of this primary attention, but it's not everything. So we cannot keep focusing on health systems because find at the end, especially in Colombia, for example, talking to health system is a web of services, and we think at the hospital, and we lost any wide notion of what is really public health or what does really mean public health that is really related with a primary attention. In this book that we published last year, we have social primary attention, a community experience at Caldas department in Colombia. You can find the experience that we have by territory. Then we have this global scenario of all the territories in Caldas and with all the experience. I would like to state this operative model that we have organized in Caldas and and then to talk of some successful strategies. And in this operative model, we find three fundamental axes: well-being and familiar health. There we can find several things. The first one, social observatory. In this one, we have the experience of variables, so much very interesting. When we visit the families, we start gathering a very valuable information where we make where we can lead us to a risk classification, which is the first determiner to uh, have the priority families. The families that are already in this system, whether there is a death or a teenager that is studying, everything is going to appear at the social observatory. So there we are going to find all the information and social determinants of each family. In this moment, we are researching on an instrument to measure the social determinants in health. And in this moment, we are validating in Colombia and can be validated in other countries once we finish. This in order to focus risks, because for because this qualify risk and non-risk, but we already know that there are diseases that are more risky than others. So this observatory is a very valuable tool. There is also the situational analysis unit. For example, a family that is at the high risk, so we can monitor and accompany this family. And then we have the attention routes that are planned according to the needs of each family. The social and community participation is the most difficult one. Nevertheless, the projects that we have reached have been with community participation and the interdisciplinary education is a requisite to have a primary successful attention. So here are some pictures of these social attention centers and at the Caldas territory. But I would like to tell you specifically from the territory. These are communities where we have attention centers. That is, for example, it's not necessary a big building, or it can be a place where the community gathers and choose to be and live this community health experience. In this case, for example, this is one of the social attention center of the 54 that we have in Caldas, and that are constituted by an administrative organization. So, necessarily, this, for example, we inaugurated several years ago, that it's in the center of the town. And there is the primary healthcare attention of the territory of the community. This is not exactly a hospital, but we are going to approach the community to the first level of attention. In this case, through you can find the last semester students of architecture, the geology, nursing, medicine, all the professions, for example. And none of this profession is more important than the other. Everyone is important. And if we don't understand this conceptually, in the praxis, is we are not going to manage to reach it. These social observatories classify these low, mild, and high risk. By coverage, we have a kind of a high coverage because, but in regarding inequity, we will only have this familiar visit to those who are in high risk. We don't have the capacity and the funding to reach all the families that may be in mild or low risk. In this graphic, we are going to see the familiar risk and how can we measure it. When we start with the family, uh, we start with an initial risk, and then after we intervene with and work with this family, the risk can be low, can decrease, for example. The observatory can also show us heat waves and where, for example, the people with hypertension or diabetes is, how can they are distributed regarding age, a group of age. The familiar accompany is the cultural focus that we have given. We work theoretical called Madeleine Lerner, and we work from the families. It is necessary that to look all the factors that a family has and use other instruments that we have worked as a map, EcoMap, family history, to work with them. And which, how many resources does that family has? How can we help them? And how can it be restructured? Definitely, it's going to be a very low percentage. Generally, everything can be helped. These are some articles that we have published centered in this familiar comprehension, and how there's an article that shows a case of how the action plan is made based on transculturality as a means. There is another that shows how do we do it from the social health determinants. There is another that is that we do regarding the popular knowledge. Important, successful. When I have a contact with the families, we manage to identify risk and we manage to present a project to improve their lifestyle. For example, these ecological kitchens and uh, water filters that require these things. So if we work in primary attention and we identify the risk and the needs of the families, we have to work structurally in order to improve those risks that the family already have in its context. From within the community participation, we've been working something very beautiful that is popular education, inspired in Paulo Freire from the knowledge dialogues with the leaders of some neighborhoods. We work cultural circles called Círculos de la Palabra, and they have been generating and mapping the risks in order to prioritize the problems they had in their communities. We have used the social cartography to avoid that that re-victimization, because it's really not to map risk, but to map all the risk and all the resources of the communities in order to help them and to work with them. These cultural circles, this is an article that we also write. These cultural circles with communitary leaders were organized as a process of dialogue to rebuild from reflection all the problems and analysis of the socially built experiences. Through produced dialogues, they were configured spontaneous spaces of reflection and conversation, and it was possible to listen new voices and discuss problems and situations. The circles have strengthened me as a people. I talk, I listen, I've seen them talk, and then I've seen myself talking. Because, for example, I am leader in the Czech. Prior, I was ashamed to talk, and but now I'm I'm becoming more strong. In these circles, we learned that we must know ourselves better and work among our neighbors. And these are some experiences. From the intersectoriality, we find some projects that were generated in a community from within a lot of disciplines. For example, a rural market, and and they generated. They find first that they're actives, and they start to improve a lot of aspects in their lives. The market was a means to improve the lifestyle quality of all the families in the community. And I believe that it is an example of a very attention level. For example, another one was the project Buen Vivir. And here we have all the capacities and the transformation that Marta Nussbaum shows us to think in a fair neighborhood. And for example, we have work in an ecological community, a cultural community, healthy community, um, healthy community, safe community, community of emotions, in order to improve to a healthy life. And context for the scholar life. And beyond the hospital and the health services, we have a lot of scenarios where the primary attention must be alive, and we have to translate all this effort to these scenarios. This is a card that uh, we issue. There are some pictures of the active community, the ecological community, the healthy community in general. This is one of the most beautiful projects, which is to grow vegetables. We call them, it was a proposal of a healthy community. As, as you can see, prior to our intervention, it was like a dump. And then we have all the community um, working in this vegetable garden that was, and all the community was helping. So the urban is not, is compatible with the agriculture, with the communitary solidarity practice, and that reflects hope in the organization of a healthy community. This was a very important experience that the WHO helped us. These are other projects that we have eh, worked with the community, and this is a new project. Um, that we saw that employment was a very important issue, and the independization of the women. And we are generating a new project called Itaquera, uh, which is based in Santana de Itaca. And what we want is that in this territory, the women that are head of the families must obtain an employment and be empowered. These are some of the writings of this project. We are butterflies that we claim for freedom. We represent diversity. Our beauty is not a stereotype. We celebrated the light in the darkness. We are happiness. We have a great deal of resilience and adaptation, and we are a case of life and evolution success. This is the project that we've been generating within the community with them, with all the women that are interested in working with us. So, how can we make the monitoring and evaluation of these projects? We're still learning from this process because we have quantitative indicators. We would also have to have this qualitative evaluation in order to lead us to know how the community values all this primary attention from the family, from the individual, the family, and the community. This is a really short way of showing you the experience in Colombia that has been communitary and most emerge from the ideas of the people that lives in the communities. Thank you, Dr. Laisa. We are very pleased with your experience in Colombia, and especially all the work that from Caldas University have been promoted, and all the transcendency and translate this integral continuum, physical and mentally state of the people, and focus this model on the communities and on the individuals for the primary attention, and this link with the territory, and especially to share this experience of primary socially attention in Caldas. Very, very interesting. Thank you. And it's focusing on the local and the first contact with the people, with the communities, and this funding challenge that we have not only at a country level, but at regional level. Thank you very much to, to tell about all the articles that you have been writing, which generate a lot of valuable information and can show us where to focus the efforts of for the needs of the population. If you allow me, we will go to the question and answer session. So we will make this feedback with the experts and the public.
Cada ponente, en particular por las temáticas que se están preguntando. En primera instancia.
So first of all,
bueno, desde luego que el resto de los ponentes.
Of course, all the panelists can participate in this part. By the thematic, we would like to ask Dr. Ricardo Pérez Cuevas, how can we strengthen a health system in which the budget for the health system is not enough?
Previo a la pandemia,
prior to the COVID-19 pandemic, health system had already a funding problem. So there are mechanisms to increase the efficiency. The first one is to define clearly the funding source. Second, to establish clearly which are the rules, the operative rules of the funding in order to identify where you can maximize the value. From the practical standpoint of view, the investment is public health and primary attention, healthcare attention. There are two topics that cannot be left aside. As I said at the beginning, the majority of the services are gathered in these services. So you have to invest in equipment, in staff, in infrastructure, in modernization. In this, we will be more effective. And the second one that I cannot leave aside is the participation and social vision. For example, what Dr. Betancourt presented is very important, but there's other areas of the government that must be involved. I am with Dr. Loaiza in this sense. To make a transversal cut, I don't think that the health system had to do everything. We have to take into consideration the community, the determinants, and in this way, it's going to be reduce the cost. In a midterm, politicians and researchers must have to work together. The politicians want quick solutions, and that is a problem. The programs must be thought in a long term. Thank you very much, Doctor. Related with this topic, we have another question. What percentage of health sector funding should be destined at the minimal level, at the first level of attention? There is a pyramid where 80% of the budget, it goes directly to the second and third level of attention, and only 15% goes to the first level. If we could balance these numbers, this 50% includes health, public health. If there would be a gradual increase of budget, and we could manage to have at least 35% destined to public health and primary attention, would be the ideal. It's difficult to establish numbers, but it depends because it depends on the region, on the country, on the budget. But we have to increase the budget in this first level of attention. Thank you very much, Dr. Ricardo. We have a question for Dr. Svetlana. The question is, Mexico, despite the fragmentation of its health system, has managed to attend the vulnerable population. What is what can you say about reaching all the population? Well, it is a very important problem, the deficiencies in the quality of the health services, and there is a lot of research in Mexico on this topic that shows these deficiencies in the primary healthcare attention in the patients with chronic non-transmissible diseases, as well as other kind of patients. And we have to strengthen the training of the physicians, all the health staff regarding the quality of attention. It's a very, very important point to strengthen health system. I would like to also add to the answer that Dr. Ricardo Perez Cuevas regarding when you don't have enough funding, what can we do really? within a health system. Actually, IMSS published a book. I will share the link with you. This book. Public health and primary attention, effective access to Mexican health. This book has really described for each health problem the strategies, the funding strategies, and it is so really there are some effective strategies that we can use to strengthen the health system. So I recommend to read this book that was published in 2018 or 2019, but it describes clearly how can you manage efficiency in a health system where there are funding deficiencies, such as the ones that Mexico and other countries in the regions and in the world are facing. Thank you.
Qué amable, muchas gracias.
Thank you very much, Doctora Boba.
Bien, pues por cuestiones de restricción de tiempo tenemos todavía una serie de preguntas, pero que si me lo permiten,
So,
dejaremos hacer llegar a...
In order to finish on time, we have several more questions, but we will give them to the panelists directly to their email because we have to close this activity. In this moment, we are going to close this event on behalf of Dr. Emilio González Carrasco, Executive Director of the Inter-American Center of Social Security Studies. We thank you all, the panelists, the participants. Thank you very much to share your experiences at the regional level in Mexico, Costa Rica, and Colombia. Thank you very much to the participants that were listening and give the questions. And thank you very much.